Hello, everyone. We will get started in just 1 minute. Good afternoon and welcome to the American Heart Association's national webinar. During today's session, we will have the opportunity to hear from Dr. Viroja on the development of a heart failure program in a skilled nursing facility. All lines will be muted and we will address the Q&A at the conclusion of this presentation. You'll have the opportunity to submit text questions by typing them into the questions pane of the control panel. You may send in your questions at any time during this presentation. If you experience any technical issues, most can be resolved by refreshing your browser. If your issue is not resolved following the refresh, please refer to the GoToWebinar customer service team, whose contact information can be found in your webinar confirmation email. Also, a copy of the slides will be attached in the webinar platform. This presentation will discuss current barriers in care and how these barriers have been addressed in communities featured. These views do not necessarily reflect AHA or ASA's official position. The AHA and ASA does not endorse any product or device. Dr. Viroja is a board-certified internist and geriatrician with extensive experience in all aspects of clinical care and clinical care management for the geriatric population. Dr. Viroja focuses on resident and patient-centered care, subacute and long-term care, as well as population health facilities. He believes in promoting wellness, disease prevention, chronic disease management, and assisting patients during acute illness recovery through specialty care services. Dr. Viroja has been in clinical practice of geriatrics for the last 35 years and has been a healthcare executive for the last 20. He has served Marquis Health Services and its facility as a chief medical officer since 2012. He is passionate about transforming care at their facilities, and he has created innovative specialty heart failure programs. Thank you again for your participation today. I will now turn it over to Dr. Viroja.
Good afternoon. My name is Dr. Viroja, and I'm privileged to be with you. We are very excited to share with you about heart failure program and how we can do innovative way for the better care outcome and quality improvement. I have no relevant disclosure. Today, let me share with you our objective and agenda. First of all, we're going to talk about understanding of heart failure, particularly into the post-acute space. Also, we will talk about benefit of investing into heart failure program. I would like to share with you successful strategy, how you can make it happen at your facility. And we will share with you our secret sauce. How did we do 24 facilities, 24 months? Our today's agenda includes, I would like to share with you today's problem. We'll talk about background information, some statistics and facts, what are our gaps, opportunities, and challenges. As well as on the positive end, I would like to share with you creating a structure, process, and outcome in the post-acute world, so you can successfully partner with American Heart Association's heart failure program to improve care quality and outcome at your facilities. And we are truly excited and appreciate you being with us today. Let me elaborate on today's problem. Last 50 years, we have made significant improvement into cardiovascular care. However, cardiovascular disease still remains the major cause of death and disability. Our healthcare system is still not equipped enough to deal with the chronic disease and not able to cope with them, heart failure being one of them. As all of you know, heart failure is a chronic progressive disease and or syndromes, which ends up in multiple hospitalizations, increased resource utilizations, higher mortality or premature mortality, as well as the significant burden of the cost. Skilled nursing facility and nursing home are in unique positions to help heart failure by fundamentally changing the new model. And that's what I like to share with you. But for that reason, we really need to have a sense of urgency. We need to clearly understand how important it is to improve the care quality and outcome of the heart failure. Let me share with you some of the statistics and facts. Almost 7 to 10 years ago, there were around 6.2 million people with the heart failure. Today, there are 6.5 million people. By 2030, it is expected we will have 8 million people with heart failure in US. One of the reasons is the incidence continue to grow up with the age, metabolic risk, and sedentary lifestyle. Hypertension and ischemic cardiomyopathy remains the two most common major healthcare problem contributing to the heart failure. And as the incidence goes up and people are living longer, prevalence goes up. At the end, 20% of the all admissions or readmissions in acute care hospitals are from the heart failure. People with the 50% heart failure will be readmitted within 6 months from the date of their discharge. Overall total cost is 40.3 billion. This is a significantly high burden to us as an economy. And not only that, it is also affecting 3.3 million people. That's a huge number of the people being affected for the quality of their life. Let me share with you, the course in 3 different ways, in terms of traditional care, in terms of palliative care, and the quality of life. Usually we get involved into traditional care, as we enter into stage C, it becomes more intensive. And as we enter into stage D, more palliative approach is being done. But as you can see in the upper half, despite all this, the quality of life declines, even if increasing intensity of the care. Let me share with you some of the missed opportunity and gaps. To begin with, we fail to make risk factor modifications. This can really make a big difference up to 80%. We also fail to understand people and people's choices and goal of care. We also have been not up to date in terms of identifying some of the chronic disease underlying, such as hypertension. 20% of the hypertension is still not recognized in a timely fashion. 30% of the cholesterol problem is not recognized and addressed in a timely fashion. This all results into end result of the heart failure. Also, we are not offering for the advanced treatment in some of the group who may be interested into that. So if I may summarize, we have a lot of good opportunities to diagnose in a timely fashion. We have good opportunities to optimize the treatment. Also, we need to understand the patient-related issues, and we will talk a little bit more about that. Acute care, hospital care, and access to the specialized care still remains a challenge. Okay? And post-discharge care, whether it is from the hospital, nursing home, or any other location, is still a challenge. And we can do certainly better in terms of transition of the care, particularly when people are going home. So let's talk about challenges. What are our challenges? So as I think back and I sit here, I think who is accountable for this, problems and management? Where are we treating people? Are we treating people in hospital? Are we treating people in subacute? Is it a community problem or is it a doctor's office problem? Are we truly balancing care, outcome, and quality while managing the cost? And let's talk about the hospital nursing home cycle recycle. People go to the hospital, 20% comes back to the nursing home, and some of them end up back in the hospital back again. So all it ends up being, we need increased support. We don't understand the total complexity, and we need to have a better approach. We understand at every level there is a limited support, inadequate system, and there is a limited capabilities. So what I would like to suggest that we need to develop a model, a disease-specific solution that we can blend with American Heart Association guidelines for the focused patient care and deliver the quality care and demonstrate that we really need to improve the care model so that we can improve the quality of life, minimize the unplanned hospitalizations, as well as help with the mortality and morbidity as a team. I'm going to take you next 4 slides about a little bit more academic part of the heart failure. Heart failure, first of all, risk factor that molds into the heart failure. That's stage A. All of you know, we're very much aware of that. Diabetes, hypertension, smoking, obesity, sedentary lifestyle. Stage B, which is a pre-heart failure. That's where other opportunities to identify in the early stages, very early symptoms, and there are nice creative lab ways we can just identify, such as by using pro-BNP. Generally, we get involved ourselves into stage C, where people are symptomatic. That's when they reach out. That's when they are being noticed or brought to us. Over the period of time, either they stabilize or progression continues, and they turn into advanced heart failure. At that time, really, we get into palliative care. So our role as of right now is in stage C and D. We need to move to stage A and B. The care for heart failure has become significantly complex. One word I really learned recently, and I really like to share with you, goal-directed medical therapy. GDMT is a huge thing. Heart failure, all of you are familiar with the preserved ejection fraction. You are familiar with the reduced ejection fraction. New emerging entities are improving ejection fraction, and other subsets are comorbidities such as atrial fibrillation, amyloidosis, and mitral regurgitation. The care continued to get more complex, and let me share with you 2022 guidelines. Now, recently, SGLT1 has been SGLT2 has been significantly utilized in all different categories: preserved ejection fraction, improving ejection fraction, as well as the reduced ejection fraction. Also, starting medication, at least 3 or 4 at the same time, even during the hospitalization, has been the gold standard. Not only that, more emphasis is being given to the amyloidosis, atrial fibrillations, converting atrial fibrillation back to normal rhythm, as well as more recently, there will be increased emphasis on stage A and stage B, primary prevention and early identifications. So the point I'm trying to make is there is a significant complex management challenges that everybody has to learn and memorize and implement. So our focus should be, in summary, new treatment understanding, multiple treatment at the same time, preventions, also comorbidity management, also look into and offer implantable devices as we go along. We at Marquis, we took this seriously. In 2014, we decided to sit back, and we were trying to figure it out. How can we make a meaningful difference into this care? As in 2014, DRG was coming out, hospitals were unloading patients in a little bit fast fashion. So we wanted to create a value. So we did our own analysis. During our analysis, few things came out. We thought, can we create a value where we can really create value for not only for our customers, but also for the system, while being an attractive employer, partner, and corporate citizen? Can we do something that we don't have to say anyone? It should speak for itself. Are we really there to do something good? And at the end, does our leaders' behavior support the idea that we can make world a better place? And we need to start with one disease at a time. I know that you all love it. I know that you all are great at it. And ultimately you get paid for it. So why not to just get involved in in a total partnership. As we were doing some analysis, we realized that we have a great opportunity at our nursing home. People are staying with us 14 to 28 days. This is around 10 to 18 days of the business days opportunities, from Monday to Friday. We have multiple providers at our facilities. We can provide oversight of the medications and diet very closely. We have a 24-hour nursing care. We have ability to provide education not only to the patients but also to the family. And this is great opportunity that we can have 10 to 14 sessions. And we really wanted to incorporate this opportunity when patients are with us. While patients are in hospital, they are not prepared, equipped, or in the good state of mind to learn about heart failure in those first 3 to 5 days. Okay. This is the opportunity we identified. So we decided to come up with the strategy. We realized that there is a lot of unwanted variation from New York to California. We also realized that patients' experience is inadequate. There are a lot of efficiency issues, and formally we are not tracking outcomes to manage patients' experience as well as rehospitalizations. We decided to align with the upstream and downstream partner as a first strategy, so we can improve the care continuum. Our strategy, 3 key parts. Coordination of the care is must during the condition across all healthcare spectrum, whether it is at the hospital level with us or in the community. All the members of the care team has to be on the same page. Second big opportunity, as I mentioned, is about education of our staff, education of the patients, and education of the family member about self-awareness. And I will share with you our zone tool about diet, about the medications. So there were a lot of good opportunities about the education. This is what will translate into prevention or early identification of the disease, and it will really help the unplanned hospitalizations and quality of life. And last thing is also to monitor and evaluate our own quality of services. So these are the 3 cornerstones we came up with. Okay. Many of you may be aware of the Donabedian model. We decided to plan our specialty program based upon this model. Pretty simple: structure, process, and outcome. As we talk about structure, we looked at our own facility structures, our equipment supplies, and our HR resources. As it relates to process is a reflection of the actions we do. So as we looked at our processes, we looked at diagnosis, treatment, prevention, care, education, and care delivery model. Not only that, technology can play a very important role into that. We decided to improve that part. And finally, outcome, both for the process matrices as well as outcome matrices, we decided to look it and have our own copy. And I will share with you as we go along. If we do everything right, we were pretty confident that we can really change the health status, behavior, knowledge, and satisfaction and quality of everyone involved. Let me share with you our program, and I'm very excited to share with you our success story. First of all, everybody has to be on the same page. Our CEO, our business development, our leaders, and our educator on the field. We all were aligned and committed. We had one dream, we have one team, and we decided to deal with one disease at a time. So in 2014 to 17, we developed cardiac and pulmonary programs. Subsequently, we added renal programs, and we wanted to power it with palliative as well as next generation rehabilitation. Cardiac rehabs cannot be started as outpatients. We have a great opportunity to get them involved while the patient is with us. And more recently, we thought as we have better hang of specialty program, we wanted to be disease specific. So 2021, I decided to partner with American Heart Association, and we wanted to be the pioneer in developing heart failure program at post-acute space. And now more recently, last year, we just got into COPD gold, and this year we are working on two journeys, which is a dementia and memory care. My goal today will be to share with you about heart failure programs and our own story. We decided to have our own mission, vision, goal, and value. We wanted to be the leader in post-acute space. Our vision was to create a specialty care program. We started with the cardiology. Our goal of the cardiology program was to achieve functional, psychological, and social functioning while improving, stabilizing, or reversing some of the heart failure related problems. And at the same time, we wanted to add education for the person involved. So we wanted to create a more patient-centric care. This will create a very differentiated care model. This way, we will be able to achieve CMS goal, and country's goal about care quality and outcome. And we will be able to meet our partners, our hospital partners, our ACOs, and our population's need. My model, pretty simple. 4 arms. We decided they are pretty integrated in each other: medical arm, rehabilitation, education, and other needs. Each arm have 3 or 4 subsets. While patients are with us, obviously our main goal is to deal with the primary disease, which is the heart failure. But that's not only good enough. We need to manage comorbidities. As all of you know, that they may have a chronic disease, they may have renal failure, electrolytes abnormality could happen. And prevention is very important. As patients are with us, we could have some challenges of blood clot, skin issues, fall. So we really need to be careful, and we wanted to be on top of the prevention. Life is never easy. It could be bumpy, and there could be early decompensation, during first 2 to 4 weeks as patients is recovering in one way, either directly related to heart failure or unrelated to heart failure. And we wanted to identify them early and intervene while patient is with us. On the other side, patient is with us because of the rehabilitations. They are deconditioned, significantly deconditioned. So obviously we want to provide them primary rehabilitations, but at the same time, we took an opportunity to get cardiac rehab involved and close monitoring by our rehab team of the cardiac status, because they are the one who has the face-to-face most contact with the patients during the 24-hour time. Also, we wanted to educate them about all DME, their need, whether if they require oxygen or anything else. As it relates to education, it is a pretty complex thing. As I mentioned, patient is with us for 10 to 28 days. Great opportunity to educate about primary disease heart failure itself. Great opportunity to educate about comorbidities, whether it is a high blood pressure, low salt diet, how to do weight, obesity, smoking, vaccinations. And also, everybody is confused about this, 20 different white pills, small pill, big pill. This is great opportunity to help them understand some basic medication management of the heart failure. And diet, I don't have to say anything more about the diet. Really, we all see that Thanksgiving come, people eat more salt and they end up in the hospital. We really need to educate while the patients are with us about low salt diet, low cholesterol diet. This is a great opportunity. At the same time, we did not want to forget about patients, their own needs. There is a fair amount of anxiety, depression, stress. Also, people have their own set of issues about transportations, buying money, about family issues, worrying about so many different things in their own personal life. So we wanted to support people every which way. So this is the model we created, and then we also created a process map. Okay, we started with the navigation plan. We reached out and partnered with the hospital system. Before even the patient comes, 3 days before, we wanted to know a little bit more about the patients. When on patient's arrival, we obviously wanted to do meet and greet, do medications reconciliation, and within 24 hours, all team member needs to evaluate the patients. We asked our hospitalists, our SNFs to see the patients within 24 hours. We wanted to have a 72 hours meeting with the patients and family. Okay. We got rehabilitation started irrespective of weekdays or weekend as best as possible. We got social service involved to help support patients for the post-discharge need, as well as we got care navigation involved to get the basic information from the hospital and or patient's previous cardiologist and whatever the cardiac workup was done. So there was a whole navigation pathway that which will have a seamless, continuous help for each other. Structure. Our structure is based upon AHA, very, very simple, but very powerful. Okay. 6 point. Personal education. It is all about HR. It is all about internal resources. It is all about internal product. Then comes the care coordination. Care coordination before, during, while patient is with us, as well as when the patient is being discharged. Clinical management, the key component, 80% of them is about clinical management. Wanted to optimize pharmacological and non-pharmacological approach. As I mentioned one more time, patients and caregiver education is key part, and I'm going to say a little bit more. And finally, performance improvement. We really needed to keep an eye on ourselves, and we wanted to manage program in a appropriate way for the better outcome and metrics driven. So I'm going to share with you each component one at a time. Personal education. Education insight of our each member about heart failure sign, symptoms, what to look for. Patient is not looking good, oxygen level going down, looks tired. Also, underutilized clinical pathway. From MDAT, they have a CHF pathway. There is no standard pathway nationwide for the post-acute, but it is emerging. We also wanted to share with everyone there is a specific way to deliver the care. Not only that, if there is any change in status, we wanted to do SBAR, we wanted to identify. In fact, we even got involved with artificial intelligence to find out patients' status change or predict based upon some variability earlier. We also wanted to be prepared for any IV Lasix, IV drip upon arrival or upon decompensation. We also wanted to share with everyone about what to monitor, develop interpersonal skill of communications, as well as stress management, whether it is a patient stress or if there is an acute situation, our own staff stress. Patient safety is also important, whether it is a skin or fall. We really wanted to train our entire team. For that reason, we decided to have all in. Everybody has to be in the same, whether it is a CNA or CEO and everybody in between. They have to be committed. We also obviously need to have improved clinical capabilities. We wanted to be the medical floor of the hospital. We needed equipment. We also wanted to make sure that there is a 24/7 ability and availability of the IV medications, IV accesses, heart monitor. We were also prepared to deal with inotropic medications, and it is an ongoing education. We are working with LVED educations, pain management. We have trained our respiratory therapists as they play a very critical role in oxygen management. The whole team has to be there. So we elevated level of the clinical capabilities across the board. Okay. Again, let's go a little bit more into care coordinations. Care coordination has been identified somewhere in the 30 to 40% of the reason for the failure and why people are ending up in the hospitals. So we start with our relationship with the hospital partners. We try to find out their diagnosis, what was done during the hospitalizations, what value we can create for the patients, and share with the patients and family. We educated case manager at hospital level. We also started educating patient's family even before patient is coming to us, what to expect, how we will be managing with them. We got them involved in all decision making. We started sharing programs of the videos, outcomes, testimonials, and more educations I will share with you. One thing we identified that was very important was the warm handoff. As we noticed somewhere in 2014 to 2018, we were getting anywhere from 25 to 200 pages from the hospital of various material come as a package. Nobody has time to go through that. We decided to implement a warm handoff at every level. SNFist needs to talk to the hospitalist, RN needs to talk to the hospital RN, rehab people will need to talk to the rehab. And each level, there is a set of check mark boxes and questions that we need to understand. It is about primary disease, comorbidities, whatever the workup was done before. Patient have advanced directive. Is there a need for advanced directive? And habits, vaccinations. We really wanted to have. It doesn't take more than 2 to 5 minutes, and it can be done in a very, very efficient way. So warm handoff has been one of the key part of our care coordination. Next, very important, our success story is based upon the interdisciplinary team. We made it mandatory that first of all, we mobilized the hospital resources to us. We started having cardiologists on a weekly basis with us. It is the cardiologist who leads along with our specialty program lead in-house. We made it mandatory to have an interdisciplinary team meeting on weekly basis where everybody is on the same page and they talk in a very systematic way. First 10-15 minutes new patients, next 10-15 minutes people who are decompensating, and then last 10-15 minutes about status quo patients, how they are progressing in all different disciplines and all different dimensions. Okay. Clinical management. We had a specific process map we decided to follow. How can we create value for the patient? Obviously screening, education, their educational background, what level, what is their post-discharge need, and how we can get them engaged. At the same time, we also decided to monitor our number of the visits by different care provider, whether it's a hospitalist, SNFist, cardiologist, our rehab team, our nurses, or our education case manager, and also came up with the specific matrices as we go along. Also, very important thing is preparing, intervening, and rehabbing specific for triple goal: patient's goal, facility goal, as well as clinician's goal. And we followed all along that across the board. Okay. We decided to have our own clinical practice guideline based upon EMDA, develop our own order set. We were working with heart failure assessment tool and tool zone. Okay. One of our success story is program lead. Our internal program lead was keeping everybody together, getting all the information, managing IDT, keeping families in loop, as well as educating patients and family, as well as collecting the clinical data as we progress. Also, all of you are very familiar with the social determinants, which is very important, and we got that integrated into our management and post-discharge planning, whether it is a housing, transportation, safety, or any other help that patients may need. Okay. Let's just touch base one more time about education, a little bit more in a different way. We decided to create a patient's own scale. We were teaching them how to use it, and we were giving them away when they go home. We had a binder at the bedside where every education's information we would like to add. And obviously whiteboard, we cannot say enough about whiteboard. We identified all the cardiac people with their own identification and patients with their own wristband, and simple one-page trifold to educate patients and family, as well as the contact number. Zone tool developed by our team has been significantly red, yellow, and green zone. Patient needed to know if they are in yellow zone, how to what to identify and how to reach out, whether they are with us or at home. It may be too late while they are in the red zone. We also wanted to educate about, again, same thing: primary diagnosis, comorbidities, diet, and medications. Performance improvement. We really wanted to keep an eye on ourselves, both about process metrics as well as outcome. Very important, about advanced care planning. American Heart Association required, 3. We decided to follow all 6 of them. Use of order set, discharge instructions, vital sign measurement, particularly weight management in a very disciplined way, and our own internal unplanned hospitalizations data, length of stay, patient satisfaction, and also medications related problem. QAPI, we put everything together. We are doing monthly QAPI for our heart failure program. Last year, we treated 1,000 patients successfully at our 24 programs that we developed, and we are a pioneer in the country successfully. So what I want to say at the end, that being partnered with American Heart Association and being certified, we elevated level of care, we improved our resources, we improved our capabilities, we have improved unplanned hospitalizations to some degree. A lot more needs to be done. I can happily share with you that we improved and standardized the care, length of stay, and medication management and medications related issues. Not only that, our hospital partners, our community partners, they are happy. We take pride in taking care of their patients and residents. We are proud to take care of our community people. So I just wanted to share with you at the end couple of things. American Heart Association heart failure certifications. What is the true value? There are three values: values for the facility, values for the patients, and values for the hospital partners. Facility value, obviously, once we are certified, people can be confident that we are maintaining high standard. We will have standardized care, no variation. Everybody will think alike. Okay, we will have a competitive edge in the market. We will be meeting the goal of CMS. We will be meeting the goal of hospital partners and ACOs. Not only that, we will have access to American Heart Association's online educational activity support, as well as the best practices. And it is a growing, advancing field. So we will be updated regularly as the standard of care continues to improve. So we as a facility, we saw a lot of value into American Heart Facility, American Heart Association's heart failure certification. On the other hand, patient's value. So far as the patients are concerned, they are given choices at the point of discharge. How do they know where to go? How they can be confident? How their loved ones and family member be confident that they are going to the facility where they will get the same superior care, just like hospitals, and everybody will be on the same page. American Heart Association heart failure certification reassures that same good quality care will be provided once the facility is certified. It is the continuation of the superior care. Hospital also wants to be reassured that in their post-acute discharge, members have the same level of capabilities as well as resources, and we are providing the same care to their patient populations, their ACO populations, and managed care populations. Obviously, the hospital have been certified for the chest pain, heart failure, and stroke by American Heart Association. Now we are into the new chapter for the discontinuity of the care in the post-acute phase. I really believe that getting certified is the way to go. During COVID in 2021, we decided to take seriously. Despite that crisis going on, we partnered with American Heart Association. We became leader. In 24 months, we certified 24 facilities, served approximately 1,000 patients last year with the heart failure, and probably around 2,500 cardiac patients. In our preliminary data, we are very happy with our outcomes. We use 6 pillars. So where is the future? So at the end, really there are a lot of great opportunities that we can do. Target approach. We can partner with the American Heart Association. It has to be a one dream across the board, one disease, one team. We all are one, whether we are acute care, post-acute care, or community partner, and it has to be one spectrum. I'm very happy to share with you our experience. I would strongly encourage to pursue relationship and partnership with American Heart Association. Thank you, Brooke.
Thank you, Dr. Viroja. for sharing this great insight. Just a reminder to ask a question. You go under the Q&A box on your screen and type in a question. While we're waiting for questions to come in, we'll jump to the next screen. Just share a little bit about what Dr. Viroja was alluding to. Before I jump into that, I just wanted to congratulate everybody for National Skilled Nursing Care Week. All the care that is being done throughout the United States, by individuals that are part of this industry, really impacts the lives of so many, and we just can't thank you enough for all the work that you do to have such a positive impact on, as I said, those patients out there. Just to talk a little bit about the certification, as Dr. Viroja alluded to, we actually began this journey in 2003 with working with hospitals. Our first certified primary stroke center, what happened, actually it went into effect 2003, first certified facility in 2004. Since then, in the post-acute space, we launched the certification for skilled nursing facilities for heart failure in 2019, and have since then developed several other certifications, including heart failure for home health, same way with palliative hospice agencies, and we have a great certification for healthy senior living, wellness certification for assisted living facilities. If you do have any interest in any of these programs, we're going to send out a follow-up email. Please either respond to that and or go on to heart.org/certified care, and we'll be able to follow up with you and work with you directly on getting you more information around that. So as it relates to the questions, I guess one of the first questions that I have, Dr. Viroja, for you is, as you put in to place your heart failure program and developed the disease-specific programs at your institutions, what would you say was your biggest challenge that you've faced over the past several years in doing that?
Biggest challenge was to put our internal team education. As you know very well, in post-acute space nursing home, there are too many things happening. Everybody is busy. However, to explain them, once we do things right, it will be saving time. It will be a more systemic approach. It will improve the outcome. So that was the biggest challenge. And once our lead team, led by Valerie and Trisha, they went to the facility, got the facility leadership, managers, and one members from case management, clinical team, rehab team, and explained to them that there is a true value. Give us some time, 6 weeks time, 1 hour in a week. And they were able to convince and show them in first couple of time that this is very interesting. This is something good we are doing. So the team got excited. Once team got excited, we were able to show you that we are prepared for the certification. And once we did it at a couple of facilities, we were able to scale right at 24 facilities in 24 months.
What would you say has been the the response or the collaboration that you've had with working with your hospital partners?
We have very positive feedback from the hospital partners. We take pride into taking care of this complex patient. There are still good opportunities that we can be together in acute, post-acute, or post-acute collaborative. We are educating them. They are learning. now that ACO is there and managed care, Medicare population is increasing, they are seeing as a better value about being on the same page. For that reason, we have cardiologists at each of our facilities and program. Our program is led by cardiologists, powered by primary care, and managed by our specialty lead in facility, whether it is a ADON or one of the cardiac nurses, and in some facilities, even respiratory therapists. So these three people really make it successful. And we are sharing our data with the hospitals, number of admissions, time, communications, and they are very happy about it. We are truly, truly excited. And it is a work in process. More and more people are learning. Cardiologists are going back to their cardiology team and sharing with them. Our hospitalists or SNFist member, they go back to the hospital partners and talk about our partnership, how we can do better. We really, even if the patient ends up in the ER, we certainly can bring back the patient. They all don't need to be hospitalized. So this is a great opportunity of sharing knowledge, being partner with them, and I'm very confident that there are a lot of good positive things we can do together. This is just the beginning. We have 15,000 nursing homes across the country and 5,000 hospitals. We really, Steve, I think we can do really good as a one spectrum, one disease, as I mentioned.
So a follow-up question to that is, in a similar way, is how have the attendings physicians embraced the heart failure program, and do they have the capability for direct interaction with consulting cardiologists?
Very good question. Thank you for asking. So one constant person is the cardiologist. Either cardiologist or their team have managed this patient in hospital. They come with us on weekly basis. Many times they are also supplying their nurse practitioner. So there is a continuity of the care. Also, for our subacute population, we enhance our ability to provide subacute level of care by SNFist model or hospitalist level of model, who are very comfortable in managing this higher acuity and higher CMI. And obviously, they are partnering at hospital level, so they were easy to partner with our level. Also, we are providing them enhanced technology. We have access to at Epic or many of the EMR as a continuity of the care. In-house, we have capabilities to support them. We have telemedicine support. We have EKG. We have educated our staff for the drips, LVADs. So there is a higher level of comfort as the patient is recovering through this acute illness. Obviously, we have partnered with one of the California company with artificial intelligence that identifies top 15 patients every day who could be at high risk for unplanned hospitalizations. And as we identify them, we share with our SNFist as well as in-house nurse practitioner, let them take a look at it, and as appropriate, we reach out to the cardiologist for their advanced guidance. So it is really going side by side as a team, whether recovering or decompensating. Very happy about just the advanced capabilities, newer way to think and newer way to partner.
One of the challenges that are commonly held in all skilled nursing facilities across the United States is staff turnover. How has developing a disease-specific program, not just your heart failure program, but your other programs, how has that helped in retaining staff? If you could speak to that, and potentially, where is it, because I think one of your slides you talked about how, it really, to a certain extent, enhances their skill set.
So let me just track back again about the organic growth we started with. We started with first pulmonary program, just to realize that there was significant value in 2014. And at the same time, we realized that cardiac and pulmonary, there is a lot of overlap. So we kind of combined them together. And over the period of next 3 to 4 years, we became from programs to the specialty program. And 2018, that translated into the division because we wanted to power with chronic kidney people, palliative group of people. While we were doing that, we also got to get to know you, and then we became more disease specific. So as we are improving, what we realized that, and we really went through a lot in last 3 years. However, even while we were going through the crisis of the COVID, we implemented, heart failure, and what we realized that our staff retention, educations, and capability improved. Their level of interest and confidence improved. Their ability to manage improved, and it is a continuous thing. And I'm very happy to share with you that across our all facilities, we had 90% high occupancy, higher than any of our competitors in Northeast, and we became the premier emerging group who put everything together. So the bottom line, if we improve the resources, capabilities, obviously outcome improves, retention improves, and experience improves, which translates into improved care and cost.
For those that may be on the line or those that watch this at a later date, what would you say would be the first steps in starting a heart failure program at their facility?
My suggestion should be the leadership need to buy in, they need to believe in. Unless we really improve the care and we invest both personal and some financial commitment for the care improvement, that is must, and it has to trickle down from top to the bottom down. Once we improve the culture, my belief is that culture survives. People come and go, but once there is a platform and there is a culture of care, that will prevail all along, and I think that's the way to go.
Can you share any key metrics? I don't know if you have them off the top of your head, such as hospital readmits reduction, outcomes.
Yes, so we did a preliminary, and we were about to publish a paper at EMDA last year in partnership with. It is an informal. We will be publishing somewhere along the line. It showed that there were around 3% improvement in unplanned hospitalizations in 2021, quarter over quarter in 3-quarter study, as I remember on top of my head, that we had done in partnership with you. And that was even in the first year. So that's a very positive news. Now, this is very complex. So one should not only count on the unplanned hospitalizations, also about the quality, experience, length of stay, decompensation. There are a lot of other dimensions and parameters that we should be following. Now that we are emerging post-COVID, I'm sure we will have a lot more opportunity to have better understanding of the data analytics, and data mining.
Thank you, Dr. Viroja. We don't have any other questions at this point. I'll turn it over to you for any closing words.
Thank you so much for participating. I think we all need to believe that we are one team, one dream, one disease, and we all need to partner across the board. We really need to believe in prevention, risk factor modifying, early identification, even before we enter the stage C. And once we are in stage C, we need a systemic approach across the board, whether it is in my office practice, whether in our post-acute space, or whether in hospital. We certainly can do in partnership with so many good societies, voluntary organizations. We will set a tone across the world, and we really have a responsibility to do that. I would strongly urge and encourage everybody to consider being part of American Heart Association and consider being certified for the heart failure for your own good. Thank you. Thank you, Steve. Thank you, Brooke.
Thank you, Dr. Viroja, and special thanks to all our participants on this call today. Brooke, I'll turn things over to you.
Yes, thank you. On behalf of the American Heart Association certification team, we'd like to thank our wonderful presenter, Dr. Viroja. our amazing Q&A facilitator, Steve Dental, and our attendees for your valuable time and participation on today's webinar.
Thank you all.
Thank you.
Thanks, everybody.